The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hi, everybody. I'm Tony Urbanek, and we're here for the next installment of TMD Demystified. Welcome to the podcast, and welcome to my office. Naomi is not with us here today. I'd hope she'd be with us a little bit, but she's off doing a lunch and learn, and so I'm going to solo today's podcast. And the topic today is specifically the protocol for using the device itself. To remind you, I didn't intend it to shape like a U, but it did. And we didn't intend to call it the Urbanek Device, but I couldn't call it the Save My Life device, and I couldn't call it a lot of things that the patient wanted to call it. Miracle device. It's like, it wouldn't come across well. But the point of today's discussion is the protocol, and that this is just a tool. It's actually a tool, a simple tool. It's actually no more complicated than a screwdriver, actually. And if you've watched enough of the episodes, now you understand that what this thing does is unloads the jaw joint, unloads the TMJ. And the protocol is there designed to unload the joints long enough and in a manner that counteracts the constant loading of the joint, because like the knees or the elbows, you can't get through life without loading these joints, either intentional or unintentionally, overloading the joints with bruxism, acute trauma, or functional malocclusion. And that's how you overload the temporomandibular joint. There's only three ways, which cause inflammation, and this is the tool that is used to unload the joint. Now, there are other tools, I think, or things available. I don't look at anyone as a competitor. It's all about how effective the tool is. I mean, I can probably take out a screw if I'm careful enough and I angle it correctly with my pocket knife, but it's much easier to use a regular old screwdriver that has the right kind of head to it, flathead or whatever, and take it out correctly, and it makes it simple. And so the simplicity of the tool is it unloads the joint. Now the protocol is designed to unload the joint adequately to counteract the overloading issues. And over time, the inflammation dies down enough so that the symptoms go away. All of the symptoms eventually. If you hang in there long enough, you'll see that the most common symptoms come down more rapidly. The least common symptoms usually take longer. And what my experience is tinnitus is the symptom that hangs in the longest. Not sure exactly why. I have some theories behind it, but they're theories. And we will have a whole separate presentation on why ringing in the ears, tinnitus, subjective hearing problems, described by most patients as feeling like their ears are full and they've been swimming and can't clear their ears, and vertigo, why those three symptoms, which are well known and accepted for temporomandibular joint disorders, why those three symptoms exist and what's happening and why inflammation in the joint directly causes those symptoms. But that's discussion for another time. So basically the first point I want to make is this is not a widget. It's just a tool. And if you know how to use the tool correctly, you'll get the response. So it developed pretty rapidly that within a short period of time, using this device, which did nothing more than separated the posterior teeth over a long enough period of time, that patients would start to get a response. You have to be able to vary the protocol somewhat. It's not locked in cement, but the protocol is very simple. For the first 2 months, first 9 weeks, it's 24/7, except when the patient is eating. They can drink with it in their mouth. Coffee, tea, soup are just fine. Hot fluids are fine. Won't distort the device. But 24/7 seems to get the best results. And then usually, not in each and every case, sometimes sooner, sometimes a little longer, but usually around 2 months, the patient is ready to move into nighttime. And nighttime is defined as every night without exception. And what I have found in treating over 3,000 patients, the case number I keep mentioning, well over 3,000 now, is that 15% of the patients find they need to wear the device a little more during the day, and 85% seem to feel that nighttime only holds them comfortable with the symptoms at bay. And most patients who use it during the day quickly figure out when they note that they're in areas or times of stress, and the ones they comment to me most frequently is when I'm on the computer or when I'm in traffic, which we have an increasing amount here around in Middle Tennessee. They've learned to put it in their mouth. And that's the simplicity of it. And then after we get them into nighttime only, we move the patient along for a couple months, making sure they don't backslide and they maintain their degree of symptom relief, which is I have a standard. I mean, a good response is 85 to 100% of their symptoms are gone or diminished consistently over a period of 2 months. And it's all subjective. There's no objective way for me to make that number. I ask the patient, take all your symptoms that you originally had, lump those symptoms all together, don't separate the symptoms out, lump them together, and average it all out, and tell me what percentage of those original symptoms, whatever they were on the list, what percentage of those symptoms are now diminished or gone. And they will give you a number. Some of them are a little hard to come up with a number. Some of them think about it. Some of them comes right off the top of their head, and someone goes, that's a pretty hard thing to do. But I just wait, and sooner or later, one way or another, they give me a percent number, and when they get up to 85 to 100% of their symptoms are diminished or gone, then we take a win on it, they take a win on it, and I consider that we're not finished, because I always invite the patient back if they have any more problems. But I instruct them how to use it, nighttime only, more during the day if they feel the need to, but not 24/7, ever, never. Why is that? Because we do know that posterior teeth do super-erupt, which is another discussion, what I've learned about super-eruption of posterior teeth. But I can tell you, adult patients 24/7 for 2 months will not cause super-eruption of the posterior teeth. Adolescents and children, yes, it can occur, and there are steps we take to mitigate that and to warn and to bring the child or adolescent's parents into it, make them aware that there can be problems, but overall, it has never been a problem once the patient understands that that can happen. So the protocol is actually very simple, and it is variable. Not everyone adheres exactly to that protocol, but the results that we've tracked using that protocol are very reproducible. And I have the results memorized from a white paper that I did many years ago, based on about, I think, 50 patients at that time. That wasn't the total load, but we just picked off 50 patients at random and did a white paper on those 50 patients. And at 3 weeks, the protocol, we see the patient back at 3 weeks after delivery of the device, then 6 more weeks after the delivery of the device. That puts them out to 2 months. And then usually 2 months after that, that brings them out to 4 months. And if we can get them to return, which is a hard thing to do sometimes, because once you get the patient pain-free, symptom-free, they see no need to come back. I see a need to come back. I want to follow them to the end, but we find that consistently, it's really hard to bring them back once we get them symptom-free, or that they're happy, whatever that means to them in their subjective manner. But the numbers are this: at 3 weeks, you ask the question, what percentage of your overall original symptoms are gone? At 3 weeks, the average is 70%. At 2 months, which is 9 weeks after delivery, it's 86%. At 4 months, it's 92, I believe it was. And then at 6 months, when we get people back at 6 months, in that 50 member study, it was, I believe, 96%. That's what I found. So the protocol is very simple. You can vary it depending on the patient's response. On many occasions, many more than one occasions, when the patient comes back at 3 weeks and they say, all of my symptoms are gone, I have a tendency to go directly into nighttime only, especially if they're adolescents, especially if they're 15, 16-year-old females. That gets you out from underneath the concern that there may be some tooth movement in soft bone in adolescence, and you get them into nighttime as soon as practical. That brings up my first thought about all this is the third cause of temporomandibular joint symptoms, which is functional malocclusion, which again opens up a whole other installment, maybe several installments, about what that means, what the definition of functional malocclusion is, how do you handle the functional malocclusions, and not being an orthodontist, but being very familiar with orthodontics, with my 40-year career doing orthognathic surgery and working with literally most of the orthodontists in my area. One time or another, I'm familiar with using orthodontic techniques to move teeth around and to create, hopefully in most cases, an occlusion that is that has the centric occlusion and centric relation similar, if not identical, which is the ideal scene. As you all know, no one naturally has a CO equals CR. So everyone has the potential to have a functional malocclusion if the difference between CO and CR are significant. Definition of functional malocclusion is a significant difference between CO and CR. And what's the definition of significant? Well, that's where it gets a little fuzzy. I won't go into that. That's, again, another installment. But again, getting back to the point of the protocol using the tool is consistent, and we use it in variable ways, but if you use it, you will get similar results. So again, to emphasize, using the tool, unloading the joint, you're balancing that against the 3 causes, and the common, consistent causes after acute trauma are bruxism and functional malocclusion. And those 2 causes you can't get rid of. If you have, without orthodontics or without getting people to quit grinding their teeth, which is impossible, there is no solution to bruxism. People are going to do it. If anyone out there thinks they have the solution, I'll be willing to listen. I definitely, make your comment, send me the email. I'll try it out. But to my knowledge, in all the patients that I've treated, I have never, ever seen anyone stop the bruxing habit. I mean, for any length of time, maybe for an hour, not for any length of time, especially at night when they have no control. So using the device to balance out the functional causes and the relief of the inflammation is purview of the tool. So it's pretty much brings to further understanding that it's not just a tool, it's not a widget. I mean, it's not a widget, it's a tool that you got to know how to use. The rate of inflammatory response is another factor that plays into this, and that's one of the reasons why the protocol isn't in concrete. It varies on many different avenues and for many different reasons, only a few of which I just want to list out here. But number one is age. Young people respond to healing very much better, quicker, better response. I think you've all seen that. I certainly saw that doing surgery, taking out wisdom teeth on a 16-year-old versus a 50-year-old. The comorbidities that go along with temporomandibular joint problems, comorbidities, they decrease the inflammatory load on the patient, symptom load on the patient, which for probably many reasons, many we don't understand, will actually limit the amount of inflammation response, whether it be good or bad. The health of the immune system itself, a whole other topic that actually I don't feel confident to talk about, even though I have a degree in anatomy cell biology. The immune system is something that we have a certain limit on our understanding and a whole lot of questions that are still out there to be answered. Just to make a side note, I just read some papers that there's some work, excellent work being done on the cure for multiple cancers based on understanding the immune system and being able to regulate the immune system, which makes total sense to me. The frequency of inflammatory incidents, that's bruxism, and the frequency of functional malocclusions, both on a day-to-day basis and and between different patients, and the degree of force, which plays into all three. The force of an acute traumatic event, which can tip off and damage a joint, and damage so severely that the inflammatory response cannot be resolved over time. The chronic inflammatory response from chronic bruxism and the amount of force that is applied by the lever arm of the jaw. And that has everything to do with the anatomy of the facial skeleton and the amount of muscle mass that moves that jaw. But actually think of the mandible as a lever arm. And because of the size of the muscles and the size of the mandible and the position of the mandible to the length, position of the mandible to the temporomandibular joint, the variable amount of force that can be made on this joint depending on muscle mass, muscle position, and length of the lever arm. High school physics. And then of course, the force that can be applied because of functional malocclusions. It's well known that someone has a huge class 3, I worked on thousands of those, a couple thousand, I guess, in my career, or a huge class 2 functional malocclusion, obviously changes the force load on the temporomandibular joint, but even a small difference, I mean, really, 4 or 5 millimeters is considered a significant COCR discrepancy, a significant functional malocclusion. So those issues are what increases or can increase inflammation within the joint. And then the tool used with proper protocol is used to modulate and decrease the inflammation within the joint. When you get to a certain point, how do you define that? Well, you define that as how much of the symptoms are diminished or gone. And when you get to a certain point where a certain degree of the symptoms are diminished or gone, you've won the battle. You're done. Unless you have a recurrence, which can happen in many cases. Some of the ones that are most obvious is the patient quits wearing the device. I've seen that. I had a patient not too long ago come in. She had symptoms again. I hadn't seen her for, I believe it was 4 years. I had seen her for 4 years. She was having symptoms again. She sit in my office. Patients are invited in my office to come back, no charge, if they ever have any problems again. She sit in my office, say, I'm having problems again. I said, well, I'm sorry to hear that. So have you been wearing your splint at night like you're supposed to? Oh, no, I haven't worn my splint in years. It's like, okay, do you still have your splint? Oh, yeah, I had it in her hand. I said, well, I think we need to start out by just putting it back in. And I followed her along. We got it back in. I gave her the protocol. We actually started out 24/7 for a while. Then we went back to nighttime only and solved the problem. Broken splints, they don't get them replaced. So there are other issues having come in with using the protocol correctly over a period of time. So I think I made that point clear and described a couple other nuances associated with inflammation within the joint. At the beginning, I think I emphasized very strongly, best I know how, look at this whole problem beginning with inflammation in the joint itself. Address that inflammation from the point of view of how anatomy works, physiology works, neuroanatomy, takes that inflammation, sends signals throughout the body to decrease or mitigate that inflammation, which explains the different symptoms, and then how to decrease the inflammation. So obviously, there are other ways to decrease inflammation. Some of them are not really good, like steroids long-term. That'll do it. But what about all the side effects? I've had other doctors inject steroids into the joint. Not a good idea. And I think that maybe someday someone will come up with a better idea, a better way to long-term decrease inflammation without causing unintended consequences. I'd love to see that. But right now, this works very well. So I appreciate your attention for this installment of TMD Demystified, and stay tuned. I look forward to speaking with you again as soon as possible. The plan is to have a brief discussion once a week, and I look forward to speaking with you again.